In the past 2 hours, we have been talking about liver cancer, and Professor Mahmood has told us a lot about liver transplantation, and he took us to the stars. And that is really good. There are 2 transplant centers in Africa, in Egypt and in South Africa. Dr. Benjamin and Dr. Sarkodie, they brought us a little down. They brought us to the moon. That's from the stars to the moon. They told us about ablation and systemic therapy. My job is to bring you guys back home. My job is to bring you to public health and bring you firmly down to earth. And being down to earth, the little baby there is fabulous. This child has had hepatitis B vaccination. This child has birth dose. This child is the future of viral hepatitis. She is the hepatitis-free generation in Africa. So that is really good. Now I have to figure out. Okay, so my talk will be brief, and I'm talking about research priorities and opportunities for advocacy in liver cancer. And the outline is as stated there. I note that many of us in the room are not hepatologists, we're not surgeons. I see that there are public health physicians. I see that there are program managers. So I'm talking to program managers, I'm talking to advocates, I'm talking to civil society and laboratory personnel. For your information, that below is the liver, in case you didn't know in the first place. The global burden of liver cancer is increasing. We've heard that today. And part of the problem is that many of our patients are unaware that they have liver disease. There's no clear symptoms. And for many of us, and for the population and the politicians, we sometimes forget that there's a 20 to 30-year delay between viral hepatitis and liver cancer. But all this talk is about preventing liver cancer. Effective treatment for people with advanced disease is lacking. Despite the transplantation, despite all the therapies, really there is no effective treatment, except you get them very early. As such, from a public health perspective, effective surveillance and early detection are essential. We've seen this slide, viral hepatitis prevalence. Viral hepatitis is the yellow line, and between 2000 and 2015, the mortality has increased by 22%. That's a big deal. While HIV, malaria, and TB mortality, they're coming down because of treatment. That's an issue. We've talked today about the fraction of liver cancer that is caused by viral hepatitis. As you will see in these graphs above, the blue is hepatitis B, and the red is hepatitis C. In Africa, nearly 70% of liver cancers are caused by viral hepatitis. So if we can control viral hepatitis, 70% of the problem is gone. And then we are left with the remaining 30% caused by alcohol, aflatoxins, NAFLD, and various other things. Over 250,000 liver deaths estimated in Africa in 2015. A colleague of mine from CDA will tell you that one person dies every 2.5 minutes in Africa from hepatitis B-related diseases of liver cancer and liver cirrhosis. One person dies every 5.5 minutes of hepatitis C-related liver cancer or cirrhosis in Africa. Now, this is our reality. I'm a hepatologist, and the patient on this top four, this is liver cancer. His first port of call was not the transplant center. You can see that his first port of call was the traditional doctor. because there are multiple scarifications on the abdomen. This other patient is also our reality. This is how we see the patients. At this stage of disease, even if you send him to Prof in Egypt, Prof will send him back home. Am I correct, sir? Great. If you send him to Ghana, Benjamin, will you send him back home? Absolutely. Perhaps systemic chemo may not send him home. All right? So in Africa, the characteristics of liver cancer are low awareness in healthcare workers, in the general population, and in the political class. Advanced stage of disease is the first presentation. When our colleague in Ghana was showing us that tiny little HCC, I smiled. I've never seen that small HCC except when I was in Mayo Clinic. By the way, the patient he showed with the small tumor, he looks like me and like you. He has no problems. Am I correct? He has no symptoms. He just walked into professor's room and he was found to have hepatitis. So most of our patients do not present at that early stage. There's also amongst healthcare workers, poor linkage of disease to hepatitis B or C acquired decades later. Our people find it hard to recognize that this patient has hepatitis B. This is what the hepatitis elimination is about, to prevent this place. We're trying to put my colleagues on this table out of work, actually. That's the plan, to put them out of work. So now there's also no data. There's no national data on liver cancer. If I ask my Minister of Health, do you have liver cancer in your country? He's going to say no, because he's going to ask his surveillance guy to look at the records. Do we have? And the records guy will say, no, we've never recorded any. There's no access to cancer care. Patients pay a catastrophic cost for liver cancer treatment. And of course, we've talked about young age at presentation. So there is a loss of demographic gains when our young men and women are dying of liver cancer. So comes in the global strategy for viral hepatitis, which was endorsed by the World Health Assembly, and we have a shared goal and vision to eliminate viral hepatitis as a major public health threat by 2030. There are two impact targets to elimination. As shown in the orange line, reduction of new infections of hepatitis B and C from about 10 million new infections per year to less than 1 million. Am I going back or forward? Yeah, back. Sorry. Okay, thank you very much. So this is to go forward? Okay. So the second impact target for the global strategy for viral hepatitis is to reduce death rates from 1.3 million people dying per year in 2015 to less than 500,000 per year in 2030. So two main impact targets for the global sector strategy for viral hepatitis. So eliminating hepatitis by 2030 has been modeled. Modeling study shows that if you do 5 things and take them up to scale, then it is possible that we can eliminate viral hepatitis and, of course, liver cancer by 2015. The 5 things are the 3-dose hepatitis B vaccination, hepatitis B prevention of mother-to-child transmission, blood and injection safety, harm reduction, and testing and treatment. The WHO region for Africa developed a scorecard for viral hepatitis to see where we are at this point in time, 2018. What is seen with the red bubble here shows that out of 47 countries in this region, only 10 countries are implementing hepatitis B birth dose. So it becomes a challenge if we cannot give birth dose that we're doing liver transplantation. Out of the 47 countries, only 8 countries have some form of public health approach to testing and treatment. So there's a lot of work to do in preventing liver cancer or in detecting it early at a stage where it's amenable to treatment. So in terms of defining our priorities, we have limited data. And the incidence of HCC is certainly underestimated, as many liver-related deaths in Africa are not identified as HCC. And even where they are identified, they are miscoded in our medical records. I have never seen a death certificate that says liver cancer. Sometimes they write cardiorespiratory failure. Am I correct? So we are not even recording or reporting liver cancer. So how can we advocate? How do we begin to know what our research priorities are when we have not evaluated the problem? And tumor registries are very important. We have visited about 8 countries for looking at the tumor registries, and one thing is consistent in Africa. All the cases in tumor registries are surgical cancers. So the tumor registry is full of breast cancer, is full of prostate cancer, but very little liver cancer, because liver cancer is not a surgical cancer. If you go to radiotherapy centers, they tell you they don't have liver cancer, because liver cancer is not radiosensitive. So we have a challenge even counting our liver cancer. So what WHO has done to promote a global standardized framework for hepatitis B and C and sort of begin to bridge the data gap. And this framework is for planning and tracking our progress towards 2030 and towards the hepatitis elimination target. And this is just an example of the framework, which is built on the results framework with inputs, outputs, and impact. Our point of interest today is the impact. The impact is C10, mortality from HCC and cirrhosis. So there are 10 basic indicators that WHO proposes to help us to evaluate the hepatitis response. And we have developed a global reporting system for viral hepatitis where governments can begin to evaluate and survey hepatitis and liver cancer, report it centrally, and it is a global dashboard and online that every country can begin to assess the burden of liver cancer that they have. I must tell you, though, that in many research centers, they have done small studies of liver cancer. But when it comes to public health, we need national reporting. We need the data manager at the surveillance unit in the Ministry of Health to have information about liver cancer. So using the 10 core indicators, I'll just show you a quick example of what we have done, and this was done in Cameroon. And there are various degrees of data accuracy. In Cameroon, there's an expected 1 million people with viral hepatitis. However, only 8% have had access to treatment. So the numbers are quite dismal. We also have assessed the cancer deaths in 2016 in Cameroon. But again, this is an estimate because we had no hard data from either the national mortality statistics. It's even hard to get death registry. In all the countries we have visited, maybe in South Africa and Namibia there's hardly any death registry. So I cannot look to see how many people died in Ghana or died in Nigeria. There's no record to say what they died of. So that, again, is a challenge in finding statistics to support a fight against liver cancer. So, in Mozambique, what was done was we did some modeling by colleagues that showed them clearly that no action is very expensive. And if they did nothing to curtail their viral hepatitis epidemic, then over the next few years, the liver cancer rate will continue to rise. This is making a case for control of viral hepatitis. So, careful mortality measurements, obviously, they are needed to generate data. And one of the proposed ways is a sentinel surveillance in sites of excellence, and this can fill the gap. WHO has developed a protocol to aid surveillance and to promote the use of standardized reporting format for uniform reporting. So liver cancer reporting in Ghana will be the same in Nigeria, will be the same in Tanzania, even in Egypt, so that the global picture will be clearer and there will be data to use for advocacy. I will not go into details, but this sequelae surveillance protocol is available online and is something we can discuss later, especially with specialists who work with liver cancer. So how do we begin to develop a research agenda for liver cancer? We need to prioritize research in liver cancer. There are various researches that are appropriate and necessary, including implementation or operational research, research promoting early diagnosis of liver cancer using blood and urine biomarkers so that the people can get detected early. Innovations are required in treatment, and some of the studies we have heard today are research studies ongoing for cancer treatment. Prevention research is also important. And of course, we have limited human resources, limited financial resources, so we have to have a process of planning and strategy to determine what to do. The other speakers had talked about international collaboration. Even regional consortia is important to promote collaborative research. What about advocacy? What is advocacy? In the earlier session, 2 questions were asked about hepatitis that nobody seems to know what is going on. So there is a need for advocacy, especially for evidence-based advocacy. You must have data in your hands to convince your government to take action. And one of the things I want to highlight is that in June 2019, we had a fantastic viral hepatitis meeting in Uganda, which was opened by the Vice President of Uganda. I think that is powerful advocacy. At that meeting, the Minister of Health of Egypt came all the way from Egypt to address the Africa group on viral hepatitis and promoting support to Africa. In the past month as well, we've been collaborating with the Africa Union. And 3 weeks ago, we were promoting the endorsement of a regional declaration on viral hepatitis. And that is certainly a catalyst for government action. The AU meeting held in this same room about 3 weeks ago, and the ministers of health from, I think, 55 countries endorsed an Africa declaration, which is being prepared for the presidents of our countries for January 2020. That is where action starts. I was also in Rwanda in December 2018, where the HCV investment case was launched. Again, that was a big advocacy, and Rwanda has gone very far in curtailing viral hepatitis in their country. In summary, reducing mortality from HCC is an important impact indicator for the viral hepatitis response globally. The development of a national database will accelerate data generation to facilitate regional and global documentation. There's certainly a need for countries to prioritize HCC and develop an appropriate research agenda. There's no way we can prioritize it if we do not know the burden of the disease. All the numbers we're hearing today are estimated numbers. And the estimated global number will not move your Minister of Health. But if you provide Ghanaian numbers to the Ghanaian Minister of Health, that is important. So national advocacy and database are important. Collaboration is key, and global partnerships are important in developing research capacity. Finally, evidence-based advocacy. I like that word. It's not just advocacy. You advocate with data. Evidence-based advocacy will accelerate dialogue with policymakers and mobilize political and community action for viral hepatitis and for liver cancer. In terms of advocacy, I think one thing that I'm seeing that is missing is we talk a lot about hepatitis elimination, and we forget to mention the HCC we're trying to avoid. I think we need to put liver cancer back into our hepatitis advocacy, because in 70% of our population, viral hepatitis is linked to liver cancer. So our dialogue has to change. We have to say that we are eliminating hepatitis because we want to prevent liver cancer. And that is a selling point for any government. So hepatitis is still a problem. It's undiagnosed, it's poorly researched, it's poorly funded, and it is poorly linked to viral hepatitis. There might be some people in this room, when we talk about liver cancer, they are not thinking hepatitis. When we go out into the community, I've been to places where they were immunizing babies for hepatitis B. And I asked the mother, why are you being immunized? If you ask them, why are you being immunized for polio? They will tell you why. Why are they being immunized for whatever else? They will tell you why. You ask them, why are you receiving immunization for hepatitis B? Neither the healthcare worker or the patient knows why they are being immunized, and that is the truth. So we have a lot of work to do. There are huge gaps. Data surveillance is a first step. And each and every one of us in this room have a role to play. Both the specialists have a role to play, the laboratory specialists, the media, advocates have a role to play. I'm a hepatologist. I've spent the past 20 years seeing liver cancer, and the prevalence did not go down. So I decided to join WHO and attack it from the root. And it's amazing that when I got out there and talked hepatology, nobody understood me. I mean, I thought it was so obvious that liver cancer is caused by hepatitis. It was not obvious. It was not. Today, I'm still struggling to tell people that liver cancer and hepatitis are one and the same. Somehow, over the years, when you talk about HIV, you know it's AIDS, don't you? HIV, AIDS. When you talk about hepatitis and liver cancer, you're talking two different diseases. And that is part of why we never recognized the epidemic of viral hepatitis. Because hepatitis C and B, they're one disease. Liver cirrhosis is another disease. Ascites is a disease. Upper GI bleeding, another disease. So we have so many endpoints in liver cancer that lead to one endpoint, liver cancer. So we all have to work together from our specialist perspective towards the common goal of viral hepatitis control in Africa. And then the remaining 30%, we can decide what to do with them. But NCDs have it, alcohol has it, aflatoxins. We can continue to deal with that once we control viral hepatitis. I thank you very much for your time, and I appreciate all the partners.